Welcome to this webinar. My name is Dr. Tom Madayag, and I will be presenting to you localizing myocardial infarction using the 12-lead ECG. So let's begin. The objectives for this webinar are the following. At the end of this presentation, I hope that you will be able to identify ECG markers of myocardial infarction, and secondly, that you will be able to localize selected infarct regions given a 12-lead electrocardiogram. In general, there are three markers for the diagnosis of myocardial infarction based on the electrocardiogram. They are 1. Inverted T waves, 2. Elevated ST segments, and 3. Abnormal Q waves. Our interest today is going to identify ST elevations because ST elevations are a manifestation of STEMI, and STEMI has to be recognized quickly in order for interventions to be effective. Just as a review, ST segment represents the period between ventricular depolarization and repolarization. It reflects the inability of the ventricles to receive any further stimulation. The ST segment begins with the J point, and the J point is in an area that lies on the isoelectric line. Whenever we're establishing the baseline always is going to be that straight line following the P wave. So in determining the ST segment, one has to look for the baseline and then compare it to the J point. The J point being the beginning of the ST segment, which is the line that connects the S wave to the T wave. A normal ST segment should be at the baseline. An abnormal ST segment could either be elevated or above the baseline, or it could be depressed. Now, ST segment elevation is not only a reflection of an acute myocardial infarction, it could also be a reflection of pericarditis. But in this discussion, we're going to talk about and focus on the ST segment elevation as a manifestation of myocardial infarction. The PR segment, as I said, is the baseline reference to evaluate the ST elevation or depression. Let's take a look at ST segment examples. Notice that in frame A and frame B, there are normal ST segments, as evidenced by the J point being on the same plane as the PR segment. If we take a look at the letter C, frame C, it shows convex elevation. Note that the beginning of the J point is above the PR segment or the baseline, and therefore this is elevated ST segment. Likewise, in frame D, if we take a look at it, the J point is clearly above the baseline, and if you note, there is a pattern of a concavity of that elevation. It really is not important to distinguish convex elevation from concave elevation. All that is important is that there is a recognition of the ST segment being elevated. Let's take a look at frame E. In frame E, if you put a line on the baseline and compare that to the J point, notice that there is ST elevation. And in fact, this is a clear horizontal elevation or ST elevation, which is beyond 2 millimeters. And therefore is going to be significant. ST depression is identified in a similar way as we identify ST segment elevations. The only difference is that in ST depression, the J point or the ST segment lies below the established baseline. Look at frame F, G, and H. It demonstrates various patterns of ST depression. ST depression in general is a manifestation of myocardial ischemia. We will focus on ST elevations. Before we go on a discussion on identifying myocardial infarction based on the 12-lead ECG, let us discuss the features of the normal ECG. Whenever we're doing a 12-lead ECG, there are 12 different leads or views that are going to be printed on the paper. Usually the format is that it begins with lead 1, lead 2, and lead 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, and V6. These would represent all segments of the heart. Now, an institution usually decides, in addition to having the 12 views or the 12 leads in the paper, they're going to add a rhythm strip. In this particular example, we have a rhythm strip that are of 3 views, V1, lead 2, and V5. Note that this could be different in other hospitals. Some hospitals might just have lead 2 as the rhythm strip, or perhaps even have 2 views, lead 2 and maybe V1. Now that we have an understanding of ST segment elevation as a manifestation of STEMI, let's go ahead and identify the different segments and subsegments of the heart. So when we view a 12-lead ECG, we could actually divide the 12-lead into different areas, which are representing particular segments of the heart. When we obtain a 12-lead ECG, we're attempting to map out the different areas or subsections of the heart. Each lead in the 12-lead ECG reflects or manifests a particular segment of the heart. An example of that would be your anterior portion of the heart. This particular part of the heart is reflected by leads V3 and V4. The septal portion is reflected by leads V1 and V2. The lateral portion are reflected by leads 1 AVL, V5, and V6. And the inferior aspect or the diaphragmatic aspect of the heart is reflected by leads 2, 3, and AVF. So what does this mean? This means to say that if there is ST elevation in V1 and V2, then that means to say that it establishes the diagnosis by 12 lead. Likewise, if there is ST elevation in 2, 3, and AVF, then that means to say that there is an ST elevation MI in the inferior portion of the heart. The implication of that is by identifying the particular segment or part of the heart that is having an MI, we know which coronary artery is occluded. The anterior as well as the septal portions of the heart are usually supplied by the left coronary artery. The lateral wall portion of the heart supplied by the circumflex coronary artery. There's one caveat. In order to diagnose any segmental MIs, there must be at least 2 leads that are manifesting ST segment elevation. What does that mean? Let's say now that we have an ST elevation in V1, but not in V2 or any other leads, then we cannot diagnose. Likewise, if we have an ST elevation in lead 2, but not in lead 3 and AVF, we cannot claim that there is an inferior wall MI. There must always be at least 2 contiguous or related leads. The leads that are related are listed on the slide. Anterior, again, is V3 and V4, septal, V1 and V2, lateral leads 1 AVL, V5 and V6, and inferior leads 2, 3, and AVF. I hope now that you have an understanding of how we establish diagnoses of myocardial infarction based on the 12-lead ECG. The next section that we will have will attempt to provide you with exercises on the interpretation of MI and localizing that particular MI. So let's proceed. I'm now going to demonstrate to you how to analyze a 12-lead ECG and evaluate it for the presence of STEMI. So here we have a 12-lead ECG, and I'm now going to look at all the leads to examine any evidences of elevation which would suggest the presence of STEMI. In lead 1, we note that the ST is below the baseline, and thus this is going to be a depressed ST segment. Let's go to lead 2. In lead 2, we have an ST elevation. In lead 3, we have ST elevation. We do not look at AVR in assessing for the presence of MI. AVR is reserved for other conditions, which is beyond the point of our discussion for today. So we ignore AVR, we look at AVL, and AVL looks like it's depressed. And AVF, it looks like it is elevated. In V1, it looks like it's slightly depressed. V2 is slightly depressed. In V3, it appears to be normal. In V4, it appears to be normal. V5 appears to be depressed, and V6 appears to be depressed. So what we're going to do now is to mark all the things, or all the leads, I should say, that are elevated, and make sure that the elevation meets the criteria for diagnosing MI. Meaning, if the ST elevations are in the limb leads, it should be elevated by at least 1 millimeter. And if it's in the V leads, it should be elevated by at least 2 millimeters. So here, clearly, we see that the ST elevations are significant in lead 2, 3, and AVF. So now let's go back to that mapping out of segments of the heart. 2, 3, and AVF happens to look at the inferior aspect of the heart. Thus, what is our diagnosis? Our diagnosis would be an inferior wall MI. I hope you're getting the hang of it, so let's go ahead and do another exercise. So let's take a look at this strip. Again, develop the system, go from lead to lead. Let's take a look at lead 1. Lead 1 appears to be slightly depressed. Lead 2 appears to be slightly depressed. Lead 3 appears to be depressed. AVL appears to be slightly elevated, and AVF is depressed. V1 is elevated. V2 is severely elevated. V3 is elevated. V4 is elevated. V5 is normal. And V6 is depressed. We notice that there are leads that are elevated, and they are V1, V2, V3, and V4. So if we were to refer to the segments that are involved, V1 and V2 represents the septal area, and V3 and V4 represents the anterior area. So what is our diagnosis then? We have an anteroseptal MI, or a septal anterior MI, and therefore this represents the pathology in the left coronary. What I'd like to do now is to ask you to do the analysis of this one that is going to come up. Let us see how you did. Okay, so in looking at lead 1, what do we have? It looks very elevated, isn't it? Okay, lead 2. Lead 2 appears to be normal, and lead 3 is severely depressed. AVL is elevated. AVF is depressed. V1 is normal. V2 is elevated. V3 is elevated. V4 is elevated. V5 is elevated. And V6 is also elevated. So let's take a look at the relationships over here. Lead 1 and AVL are relatives, and they're also related to V5 and V6. So which means to say that if there is ST elevation in lead 1, AVL, V5, and V6, then we could say that the patient has a lateral wall MI. This represents a pathology in the circumflex coronary artery. Now, there are other ST elevations, however, right? V2 is elevated, but V2 cannot stand alone. In order to have a diagnosis of a septal wall MI, we have to have both V1 and V2 elevated. But it's only V2 that's elevated, so we can therefore discard that one. Now, however, we have ST elevation in V3 and V4, and V3 and V4 are going to be a reflection of the anterior portion of the left ventricle. So this patient is very sick. We all know that the anterior portion of the ventricle is going to be supplied by the left coronary artery as well. And thus, this constitutes a severe pathology on this patient. So in summary, we have ST elevations in 1, AVL, V5 and V6, which is the lateral portion of the heart. In addition, we have ST elevation in V3 and V4, which is the anterior portion of the heart. And despite the fact that we have ST elevation in V2, we cannot claim that this patient has a septal wall MI simply because V1 is normal. Let's now analyze this ECG strip. Lead 1 is elevated. Lead 2 appears to be normal. Lead 3 is depressed. AVL is elevated. AVF is depressed. V1 is elevated. V2 is elevated. V3 is elevated. V4 is elevated. V5 is normal. And V6 is normal. I hope you're all doing well. I'd like for you to pause the tape at this time, analyze again the ECG strip, and we will discuss after you had analyzed them. Thank you. Let's go ahead and analyze this ECG strip. Lead 1 is normal, lead 2 is elevated, lead 3 is elevated, AVL is depressed, and AVF is elevated. V1 is normal, V2 is normal, V3 is normal, V4 is elevated, V5 is elevated, and V6 is elevated. I want to caution you that V4, V5, and V6 have an ST elevation of 2 millimeters, and you probably will not be able to see this unless you enlarge the image or you use a magnifying glass. But in my end, since I'm able to magnify the slide, it is showing that the ST elevation in V4, V5, and V6 is at least 2 millimeters. So in summary, the ST elevations are found in lead 2, lead 3, and AVF, and these leads all are related, and they are a manifestation of an inferior wall MI. In addition to that, there is an ST elevation in V4, but V4 does not have a partner. V4, in order to be considered significant, should be in association with lead V3. But V3 in this case is normal, and so we could ignore the ST elevation in V4. However, there is significant ST elevation in V5 and V6, which therefore points to a lateral wall MI. So in addition to the inferior wall MI manifested by 2, 3, and AVF, we also have a lateral wall MI as manifested by V5 and V6. Alright, let's go ahead and discuss this last strip. Lead 1 is depressed, lead 2 is elevated, lead 3 is elevated, AVL is depressed, AVF is elevated, V1 is elevated, V2 is normal, V3 is elevated, V4 is elevated, V5 slightly elevated, and V6 slightly elevated. So let's discuss the findings in this electrocardiogram. We have ST elevations in lead 2, in lead 3, and AVF. We know that these three leads are related. They reflect pathology in the inferior portion of the myocardium. So we can say that there is an inferior wall MI. Then we have ST elevation in V1, but none in V2. Because there's no relationship or there's no partner for V1, we therefore can disregard this. Additionally, V3 and V4 are elevated and they are together to reflect changes in the anterior wall. So we can say that in addition to the inferior wall MI, we have an anterior wall MI as well. Note that in V5 and V6, yes, there is elevation. However, it's very minuscule, very slight. It does not meet the criteria of at least 2 millimeters in the V leads. Thus, we ignore this. So, the general interpretation of this strip then is there is STEMI in the inferior as well as the anterior leads. That concludes our discussion on diagnosing myocardial infarction via the 12-lead ECG. It was my pleasure to be with you today. I hope that you have gained understanding as far as diagnosing myocardial infarction through the 12-lead electrocardiogram. I look forward to meeting you again, and please fill out the survey. At the end of this presentation, it will give you the link for that particular survey so that you can give me your feedback. Your feedback always is going to help improve these presentations. Thank you and be safe. Bye-bye.